very good evening, dear colleagues and fellow medical professionals. I am Dr. Abha from the Medical Communications team here at DocPlexis, and I'm pleased to have you here for World Hepatitis Day to raise awareness about viral hepatitis and its impact on global health. The day serves as an opportunity to bring attention to the importance of prevention, testing, and treatment of hepatitis. Viral hepatitis causes 1 to 4 million deaths yearly, and this is mainly driven by hepatitis B and C. In response to the rising prevalence of hepatitis, the WHO has developed a global strategy for viral hepatitis, which includes raising awareness about the disease, preventing transmission, and improving access to care. Having complete knowledge and recognizing the early signs of hepatitis is critical for better clinical outcomes. To get more insights on viral hepatitis, we have renowned community medicine specialists, Dr. Hetal Rathod and Dr. Amitav Banerjee. Dr. Hetal Rathod is a professor in community medicine with vast experience in public, environmental, and occupational health. Dr. Rathod has a keen interest in research and has published more than 20 research articles in reputed journals. Dr. Amitav Banerjee has served in the Indian Armed Forces from 1978 to 2005. He started working as a professor and subsequently as the head of the Department of Community Medicine at Dr. D.Y. Patil Medical College, Pune. He has published over 100 papers in national and international journals and has undertaken several research projects. He has also delivered many keynote addresses at national and international conferences. So without further ado, let's get started, requesting the speakers to share their views.
Good evening, everybody. I'm Dr. Hetal Rathod, and my colleague Dr. Amitav Banerjee will be discussing viral hepatitis causes, prevention, and control.
So the term hepatitis means inflammation of the liver, and viral hepatitis may be defined as infection of the liver caused by viruses. There are different types of hepatitis virus, and the common routes of transmissions I'm mentioning here. Hepatitis A virus, the predominant mode of transmission is fecal route. Hepatitis B virus, which is transmitted by parenteral and sexual route. Hepatitis C virus, again by parenteral and sexual route. Hepatitis D virus, which is known as a Delta virus, again by parenteral and sexual route. And hepatitis E virus, the predominant mode of transmission is fecal-oral route. Now, when infected with any types of hepatitis virus, the presentation differs. Some are going to be asymptomatic, some are going to develop acute hepatitis, and some will develop chronic hepatitis. The chronic hepatitis is in infection with hepatitis B virus, hepatitis C virus, and hepatitis D virus. Hepatitis E virus causes acute hepatitis in most of the cases. However, in immunosuppressed patients, it will lead to chronic hepatitis. Now, these are the common signs and symptoms of acute hepatitis. Fever, chills, headache, fatigue, generalized weakness, anorexia, nausea, vomiting, dark urine, and jaundice. Now, let's see hepatitis A. Hepatitis A was formerly known as infectious hepatitis or epidemic jaundice. It is the most common cause of viral hepatitis in children, and most of the population is infected asymptomatically in early childhood with lifelong immunity. Now, what is the natural history of hepatitis A? Hepatitis A, when it is infecting children, more than 70% of cases are asymptomatic infection. But when it infects adults, more than 70% of cases are symptomatic acute hepatitis. And this symptomatic acute hepatitis, out of all these cases, less than 1% will go into acute liver failure, that is fulminant hepatitis. Now, this hepatitis A is endemic in developing countries. High proportion of asymptomatic cases are seen here. The countries are categorized into different, endemic zones based on the number of cases as well as the age group which has been affected. Now, in the high endemic zones, most cases occur in early childhood and they are asymptomatic. Now, why it is so? Because the sanitation and hygiene is very poor. So the transmission occurs very fast in children, and most of these children who are infected, they remain asymptomatic. Then comes the intermediate endemicity. Here the cases are seen in late childhood and early adulthood. Now, what happens in this intermediate endemicity zone? Here there is a transition from a poor sanitation to a better sanitation. So in a country, you will find some groups which are having poor sanitation, which are high endemic. And some areas where the sanitation has improved, they are now in intermediate endemic zone. So the cases will be seen in late childhood and early adulthood. And there is zones where the disease occurs mainly in adolescents and adults, which are in basically clusters among people who are intravenous drug users or men having sex with men. So they are in the specific groups. So this hepatitis A is highly endemic in Central and South America, Africa, Middle East, Asia, and Western Pacific. Approximately 1.5 million clinical cases of hepatitis A occur worldwide. Hepatitis A virus is endemic in India. And there are many outbreaks due to hepatitis A in India. So prevalence of hepatitis A in the world, you can see the high endemic zones are Africa and India. Let's see the epidemiological determinants. Agent factors, it is hepatovirus, type enterovirus. It is resistant to heat, chemicals, and not affected by chlorine in the usual doses. It survives more than 10 weeks in well water. It is killed by formalin, UV rays, and if you boil the water for 1 to 5 minutes, it will be killed. The reservoir of infection is humans only. So the cases ranges from asymptomatic to severe cases, and period of infectivity is 2 weeks before to 1 week after the onset of jaundice. Infective material, feces, blood, and serum. So the virus excretion takes place 2 weeks before and 1 week after onset of jaundice in blood. The incubation period is 15 to 50 days on an average. Now, modes of transmission. Now, modes of transmissions are very, very important because your prevention and control will be directed towards this. So, what are the modes of transmission? Now, here can you see the contact with contaminated food or water? This is the most important mode of transmission. So, consumption of raw or uncooked shellfish or vegetables or other foods, consumption of food contaminated by infected food handlers. So, this is the most common mode of transmission. The other modes of transmission are blood transfusion, which is during the viremia phase. Then people who are using drugs, IV drug abusers, they are also at risk. And person-to-person transmission, which occurs in households due to sexual transmission, especially oral and anal sex, among the military personnel, daycare centers, and residential institutes. Adults have signs and symptoms of illness more often than children, and the severity is also more in older age. Pregnant women are also at high risk of complications due to hepatitis A infection. Complications, there are some of the complications: cholestatic hepatitis, relapsing hepatitis, and autoimmune hepatitis. Now, who are the high-risk groups for hepatitis A? People who are living in poor sanitation, having lack of safe water, people living in household with an infected person, a sexual partner of someone with acute hepatitis A infection, people who are using IV drug, abusers, traveling to areas of high endemicity without being immunized, military personnel, laboratory workers who handle the hepatitis A virus, childcare centers, and people who are unvaccinated or previously not infected. These are some of the diagnostic tests. We got rapid diagnostic test and we have got RT-PCR for confirmation of the diagnosis. So when you diagnose, what do you look for? You look for HV particles or antigen in feces. You look for the rising anti-HV titer and IgM and IgG antibodies. Treatment. Now there is no specific treatment for hepatitis A. So the therapy is aimed at maintaining comfort and adequate nutritional balance. Patient has to avoid alcohol and patient has to avoid the hepatotoxic drugs. Post-exposure prophylaxis can be given. So we have got immune serum globulins, which can be useful for post-exposure prophylaxis. It should be given within 2 weeks of exposure. And hepatitis A vaccine can be used for pre and post-exposure prophylaxis. So how to prevent hepatitis? As I said, modes of transmission are very, very important because you are going to target your prevention and control towards them. So what should we do? Improve the sanitation, food safety, and immunization are the most effective ways. Adequate supplies of safe drinking water, proper disposal of sewage within communities, personal hygiene practices such as regular hand washing before meals and after going to the bathroom. Control of reservoir, so give adequate rest, disinfection of feces and fomites with 0.5% sodium hypochlorite. Transmission can also be controlled by purification of water, and the free residual chlorine should be more than 1 milligram per liter. People who are traveling to the endemic countries, they should be advised to take vaccine as well as eat properly cooked food. Specific protection for hepatitis A, we have got live and inactivated vaccines. The hepatitis A vaccine is recommended for children more than 12 months old, given parenterally. 2 doses are given 6 months apart, and it is not given to children less than 1 year of age. The vaccine is available in combination with hepatitis B also, where the schedule is 3-dose schedule, 0, 1, and at 6 months of age, 6 months duration. There's a live attenuated vaccine which is available, which is given as a single subcutaneous dose. Now, there are some hepatitis A outbreaks, so outbreaks in healthcare settings, outbreaks among homeless individuals, outbreak among army camps. So this hepatitis A virus is prone to outbreaks. In India, from 2017-2021, we have got almost 84 outbreaks. Taking hepatitis E. Now, why I have taken hepatitis A and hepatitis E, together? The reason is that the predominant modes of transmission are similar in both these viruses. So let's see hepatitis E. Now, this disease was recognized first as a distinct clinical entity in the 1980s when the sera from persons affected during a large waterborne epidemic of viral hepatitis during 1955 to 1956 in Delhi, India, and another epidemic in Kashmir were found to lack serological markers of acute hepatitis A and B. So they could not find what is the positive agent. So they labeled it as the enterically transmitted hepatitis non-A, non-B. And later on, it was given the name as hepatitis E. So hepatitis E virus is basically earlier known as the enterically transmitted hepatitis non-A and non-B. It is essentially a waterborne disease. Hepatitis E is found worldwide and different genotypes are there. In India, genotype 1 is found. Transmission, fecal-oral route is the main transmission mode, and fecal contamination of drinking water is the most important one. Foodborne transmission through ingestion of infected animals. It can be transmitted through transfusion of infected blood products, and there can be chances of vertical transmission. The incubation period is 3 to 8 weeks. Symptoms. The symptomatic infection is more common in young adults, and the infection in children, they are basically asymptomatic. Infection lasts for 1 to 2 weeks. Fulminant hepatitis and complications are more common in pregnant women. So compared to hepatitis A, hepatitis E is having more complications in pregnant women. Diagnosis based on the detection of specific IgM and IgG antibodies of the virus in the blood and RT-PCR test to detect virus RNA in blood or stool. Treatment, it is a self-limiting disease. Prevention is the most effective tool as there is no specific treatment available. And hospitalization is required in case of fulminant hepatitis and in pregnant women. And avoid the drugs which are hepatotoxic. So prevention is the most important thing here. Maintain the quality standards for public water supply, proper elimination of sanitary waste. So when we say the quality of water supply should be maintained at the what we say, where the disinfection or purification of water takes place, there it may be adequately purified and disinfected. But once the water is in the distribution system, the contamination can occur. So when the contamination occurs in the distribution system, that time also the chances of outbreaks are very high, both with hepatitis A as well as hepatitis E. So we have to take care at both, at the, where the disinfection and purification takes place, there also it should be adequately done, as well as in the distribution system also we have to take care of the water quality. Then proper elimination of the sanitary waste is also very important. At the individual level, this can be reduced by maintaining hygiene practices such as hand washing, avoid drinking water and taking ice of unknown purity, and adhering to safe food practices. In 2011, first vaccine against hepatitis infection was registered in China and Pakistan. Okay, the name is Vicolin, but it is not available globally. So predominant HIV genotypes in different parts of the world. So you can see this genotype 1 is prevalent in India and in some parts of the Africa. So now let's go to the next, viral hepatitis, that is hepatitis B. Now this hepatitis B was earlier known as serum hepatitis, tattoo jaundice. Now, in the world, let's see what is the prevalence of hepatitis B virus. In the world, 3.8% of general population are suffering from hepatitis B. In India, from a study, the range is 0.87 to 21.4%. So the upper range is very, very high. And in the Maharashtra, it is 0.94% in general population. The countries have been divided into 3 epidemiological patterns. Type 1, where the hepatitis B surface antigen carrier rate is low, that is 0.9 to 1%. So the countries like Nepal and Sri Lanka, they fall into this particular zone. Type 2 is intermediate carrier rate, which is the range of hepatitis B surface antigen carrier is 5 to 7%. And India falls in this particular zone. And type 3 is high carrier rate, where the surface antigen carrier rate is 9 to 12%, and it is seen in Bangladesh and Korea. Now, the NFHS 4 survey, it showed that seroprevalence of hepatitis B was maximum in Andhra Pradesh and Telangana. We need to find out the reasons why it is more in this particular states. Agent, this particular virus was discovered by Bloomberg in 1963. It is a double-shell DNA virus. Man is the only reservoir, and it is present in blood, vaginal secretions, semen, as well as in the menstrual blood. Virus can survive for 7 days on environmental surface. And this is very, very important because it can survive on the environmental surface. That means outside body, it can survive for long duration and it can be infective also. Virus is present in blood during incubation period and during the acute phase of illness. In the chronic cases, it can present for many, many years. It is easily destroyed by sodium hypochlorite by doing autoclaving. Now, these are the signs and symptoms of hepatitis B infection when there is presentation in the form of acute illness. So, what is the natural history of the disease? The acute infection which occurs in adults, what happens? The recovery is in 99% of the cases. So the chronic infection is very, very minimal when the infection occurs in adult age. But if the infection occurs in children, especially the perinatal and first 5 years of life. Then the chronic infection is seen in many children. Okay. So we want to prevent this perinatal transmission of infection as well as infection to children below 5 years of age. What happens if someone develops chronic hepatitis? If chronic hepatitis case is there, chances of cirrhosis after 10 to 20 years of their infection, and then it can lead to decompensation or can lead to hepatocellular carcinoma. Chronic HBV infection accounts for approximately 50% of the total hepatocellular carcinoma cases, and virtually all of them are childhood hepatocellular carcinoma. The incubation period is 30 to 180 days. Now, these are the modes of transmission. Again, modes of transmissions are very important because we are going to focus on this for our prevention and control measures. So what are the modes of transmission? Blood transfusion, unprotected sex with multiple partners or someone who is having the infection, men having sex with men, infant who is born to infected mother, contaminated drug needles. Okay, so people who are using IV, drug, sterile tattooing needles, contaminated dialysis equipments, non-sterile dental practices, non-sterile body piercing equipments, and contaminated vaccination equipments. So we have to be very careful. If we are not going to take preventive measures in this, then the number of cases will surely increase. How children get hepatitis B infection? Vertical transmission from mother to child, and horizontal transmission, that is from child to child. So who are the high-risk groups for hepatitis B? Surgeons, they are estimated to be 50 times greater at risk than general population. Recipients of blood transfusions, healthcare and laboratory personnel, homosexuals, prostitutes, percutaneous drug abusers, infants of hepatitis carrier mothers, and recipients of solid organ transplant and patients who are immunocompromised. So what happens if there is acute hepatitis and chronic hepatitis? Now, children who have been perinatally infected, only 1% of them are going to show acute hepatitis phase. If the infection occurs in early childhood, that is 1 to 5 years of age, then 10% will show only acute hepatitis phase. But the infants who are perinatally transmitted, 80 to 90% of them will develop chronic infection. And if this occurs up to 6 years of, if the infection occurs between 1 to 6 years of age, 30 to 50% of them will become chronic infections. So the development of chronic hepatitis B infection is inversely related to age. So lower the age of infection, more chances of them becoming chronic hepatitis cases. Diagnosis can be done by rapid diagnostic test or some laboratory-based immunoassays and RT-PCR. So there are some diagnostic markers of hepatitis B. HBsAg, if it is found, it indicates that the disease is there, person is infective. If it is more than the presence of HBsAg more than 6 months, it suggests chronic infection. Anti-HBs presence indicates recovery or immunity with vaccination. And HBV DNA, if it is present, that means it shows that the virus is replicating and the person is continuously infected. So as I said, prevention is very important. So what are the preventive measures in hepatitis B disease? We have got vaccine-specific protection in the form of monovalent vaccine, and is fixed combination with pentavalent, as well as with the hepatitis B vaccine, hepatitis A vaccine, Whenever you are giving hepatitis B vaccine at birth, it has to be a monovalent vaccine only. Now, hepatitis B vaccine has been, as part of our national immunization schedule in India. It should be given at birth within 24 hours of the birth. When we are giving the vaccine to children, it is 4-dose schedule. That is, the first dose is given at birth. The second dose is given, which is given at 6 weeks, 10 weeks, and then 14 weeks. So it is a 4-dose schedule for children. Adult, the dose is 1 ml at the baseline, then you give at 1 month interval and then 6 months. Deltoid muscle is the preferred site. Infants and children under 2 years of age, the preferred site is anterolateral aspect of thigh. As I said, dose at birth is followed by 3 additional doses at 6, 10, and 14 weeks with either DPT or pentavalent vaccine. The minimum recommended interval between doses is 4 weeks. Now, this is very important. The first dose of hepatitis B vaccine should be given within 24 hours after birth to prevent perinatal transmission. In adults, routine pre-exposure vaccination should be considered for high-risk groups. Hepatitis B immunoglobulins are also available, which is basically passive immunization. By giving hepatitis B immunoglobulins, we are giving passive immunization. Now, for whom this is indicated? It is for immediate protection for those who are acutely exposed to hepatitis surface antigen positive blood. So, who are at risk? Who are at the highest risk of this? Surgeons, nurses, or laboratory workers, newborn infants of carrier mothers, sexual contact of acute hepatitis B patients, and patients who need protection against hepatitis B virus infection after liver transplantation. So what do we do when there is an accidental prick? The hepatitis B immunoglobulins should be given as soon as possible, ideally within 6 hours, preferably not later than 48 hours. So what do? We take the victim's blood and we check for hepatitis B surface antigen. If it is negative, then we have to give passive vaccination by giving hepatitis B immunoglobulins, and we have to also start active immunization by giving hepatitis B vaccine. If the person is having antibodies against hepatitis surface antigen, then no further action is required. 2 doses of hepatitis B immunoglobulins given 1 month apart, they are sufficient. So this active and passive immunization simultaneously is practiced for post-exposure prophylaxis for prevention of hepatitis B. So this combined procedure is ideal for prophylaxis of person accidentally exposed to blood known to contain hepatitis B virus, or prevention of carrier stating newborn babies of carrier mothers. So specific protection in the form of hepatitis B and the passive, immunization in the form of hepatitis B immunoglobulins are very important. However, the preventive measures should be in the form of screening blood donors for hepatitis B infection. We must encourage voluntary blood donation. Health personnel should be alerted to the importance of adequate sterilization of all instruments and to practice the simple hygienic measures. And carriers should be told not to share razors or toothbrushes and use barrier methods of contraception, and they should not donate blood. Treatment is supportive as the infection is self-limiting. Care is aimed at maintaining comfort and adequate nutrition. Chronic hepatitis B infection can be treated with drugs. Why do we give treatment to chronic hepatitis B infection cases? The treatment can slow the progression of cirrhosis, reduce incidence of liver cancer, and improve the survival. So the WHO recommends the use of oral treatments, tenofovir or entecavir, as these are the most potent drugs to suppress hepatitis B virus. There are few side effects, so requires only limited monitoring. People who start hepatitis B treatment must continue it for life. Let's go to hepatitis D virus. Hepatitis D, 5% of HBsAg positive patients have hepatitis D co-infection. In India, the seroprevalence of hepatitis D virus among hepatitis B surface antigen positive cases in northeastern part of the country is 4.2%, and in central India it is 2.1%. So hepatitis D virus is basically a delta virus. It is defective hepatitis D RNA virus that needs hepatitis B virus for replication. So hepatitis D infection cannot occur singly. It will be associated with hepatitis B virus infection. So it can occur in the form of co-infection or superinfection with hepatitis B. What are the modes of transmission? Percutaneous or sexually through contact with infected blood or blood products, and the vertical transmission is rare. So as I said, it can occur as co-infection or superinfection. So what is co-infection of hepatitis D with hepatitis B? The acute hepatitis D infection acquired at the same time of hepatitis B infection, and which is typically indistinguishable from acute hepatitis B alone. Whereas the superinfection, development of acute hepatitis D infection in a patient with pre-existing hepatitis B infection. So the patient is already having hepatitis B infection, and now later on the patient gets hepatitis D infection. That is superinfection. Prevention and control, it requires hepatitis B, for its kind of causing the pathology. So whatever measures will take for prevention of hepatitis B, it will definitely prevent hepatitis D also. Now let's go to hepatitis C. Hepatitis C, the new infections occurring per year are almost 1.5 million. The highest burden of disease in the Eastern Mediterranean region and European region. Approximately 290,000 people die from hepatitis C, mostly from cirrhosis and hepatocellular carcinoma. So what is the seroprevalence of hepatitis C in India? The seroprevalence of hepatitis C was highest in Mizoram, Manipur, and Nagaland states of India. So hepatitis C virus belongs to the genus of Hepa C virus and member of Flaviviridae. It is an RNA virus. The natural history of diseases like this, once the infection occurs with hepatitis C virus, 55 to 85% of people will develop chronic hepatitis. Out of them, 20 to 30% will develop cirrhosis after 20 to 25 years, and some will develop hepatocellular carcinoma, and they will lose their life. The incubation period is 2 weeks to 6 months. So once there is HCV exposure, it can lead to acute HCV infection. The presentation will be either symptomatic or asymptomatic. Now here can you see 80 to 90%, 85 to 90% are asymptomatic infection, whereas the symptomatic hepatitis is seen in 10 to 15%. Now out of this, both the categories, chronic infection will develop. They will go to chronic active hepatitis, and the cirrhosis will be seen in 10 to 20% individuals. Signs and symptoms of hepatitis C, symptoms of acute hepatitis C. Many people newly infected with the hepatitis C virus don't have any symptoms and they don't look sick. Chronic hepatitis, with chronic hepatitis C, most people with chronic hepatitis C don't have any symptoms or have only general symptoms like chronic fatigue and depression. Eventually develop chronic liver disease from mild to severe form. Extra hepatic manifestation of hepatitis C infection. People can have skin diseases, hypertension, neuropathic pain, renal insufficiency, like that. Now, transmission of hepatitis. As I said, transmission of any disease is very, very important. It's a bloodborne virus. Most infection occur through exposure to blood from unsafe injection practices, unsafe healthcare practices, unscreened blood transfusions, injection drug users, sexual practices, and infected mother to her baby. Among the healthcare workers, the transmission rate of hepatitis B virus and hepatitis C virus is greater than HIV. Now, we all know that these three important bloodborne diseases, hepatitis B, hepatitis C, and HIV, the modes of transmissions are similar. So if we take care, these modes of transmission, if we try to focus our prevention and controls over them, we will be able to control these infections. Diagnostic test for hepatitis C. So we have got rapid antibody test. We have got the, we can test the hepatitis C virus RNA by RT-PCR. So this is the recommended testing sequence. Hepatitis C virus self-testing should be offered as an additional approach to hepatitis C virus testing at service centers. Hepatitis C virus self-testing does not provide a definitive diagnosis of chronic hepatitis C viral infection. So we have to confirm it with laboratory investigations. Hepatitis C infection, which occurs in people, if it is confirmed with the presence of hepatitis C viral, the RNA virus, then what should we do? So we have to first find out whether the person is having cirrhosis or the person is not having cirrhosis. If the person is having cirrhosis, then we have to treat the person with antivirals. Here also, people who are having cirrhosis, we have to treat them with antiviral. After 12 weeks, we have to again check for the hepatitis C virus RNA. If hepatitis C virus RNA is not detected, that means the patient has been, treatment has been completed. If the hepatitis C virus RNA is detected, then we have to refer this patient to higher centers for further management. So an individual diagnosed with hepatitis C virus needs treatment. The duration of treatment will depend on the several situations such as presence of cirrhosis or non-cirrhosis, presence of decompensation, treatment naive versus treatment experience. So a person who is a new case, who has never received any treatment for hepatitis C, and treatment experience, that means person has been already given some treatment for hepatitis C. So directly acting antivirals are the recommended first line treatment in India. So though treatment is available for hepatitis C, prevention is more important. So what do we do? Safe and appropriate use of healthcare injections, safe handling and disposal of sharps and waste, provision of comprehensive harm reduction services to people with injecting, the people who are the drug abusers. So what we have to do, we can give them the new syringes so that they are not using the syringes of other people. We can give them alternative that from, they can shift from injectable drugs to oral drugs. So ideally, we have to ask them to stop the drug use of any form. But if they are still into that, then we have to provide them the safe methods by providing them sterile syringes, as well as they can change the route of administration of drugs. Testing of donated blood for hepatitis B and hepatitis C, training of health personnel, and promotion of correct and consistent use of condoms. Secondary and tertiary prevention for people infected with hepatitis C virus, WHO recommends education and counseling on option of care and treatment, vaccination of, person for prevention of hepatitis A and hepatitis B. We all know that hepatitis A, B, and E, all they infect liver. So if you want to prevent more damage to liver, we have to vaccinate people with hepatitis A and hepatitis B who are infected with hepatitis C. There is no specific vaccine for hepatitis C. Remember, there is no specific vaccine for hepatitis C. So early and appropriate medical management is the most important thing. Regular monitoring for early diagnosis of chronic liver disease, and the person who is suffering from hepatitis C infection should avoid alcohol, because alcohol also injures the liver. So what are the strategies by World Health Organization for control of hepatitis C and hepatitis B? The WHO has recommended global health sector strategies for HIV, viral hepatitis, and sexually transmitted infection. And goal of this is to end HIV/AIDS, viral hepatitis B and C, and the sexually transmitted infection by 2030. In India, we have got a national viral hepatitis control program, which aims to combat hepatitis and achieve countrywide elimination of hepatitis C by 2030. It also aims at achieving significant reduction in the infected population morbidity and mortality associated with hepatitis B and C, and reduce the risk of morbidity and mortality due to hepatitis A and E. Now, just for the information, there is new virus which has been identified, which has been labeled as hepatitis G, which has been discovered in 1996. And the prevalence of infection is not known. So some of the studies have mentioned this, and few publications provide information on the association of hepatitis G infection with blood transfusion in India. So World Hepatitis Day is celebrated on 28 July, and this year's theme is One Life, One Way. Thank you.
Thank you, Hetal. That was an excellent presentation. And for information of viewers, Dr. Hetal Rathod has recently taken over as HOD of our department, and I am a little free nowadays. But that was an excellent presentation. So I can now rest on my laurels. And I had some experience in the armed forces. So I would be just presenting one outbreak which we investigated almost 20 years ago. So earlier I thought this would not make sense, but when I saw the literature, we are still getting outbreaks of hepatitis. It was a waterborne outbreak, as Dr. Hetal had brought out. It was an outbreak of hepatitis E in a military training center. We had investigated it, and we had published. It's available. The publication is available. We will be just discussing that. So rapidly, I will give an overview, just like textbook picture how hepatitis E can affect when there is contamination of water supplies. So we had it was somewhere in the 2003, large number of cases with jaundice in a military training center in North India. So we had I was looking after this mobile epidemic team from the FMC. So we had gone with a team of epidemiologists, microbiologists, hepatologists to investigate the regimental center. And I just discussed those, what are our findings and how. And unfortunately, we are still having the same issues nowadays. I saw more than almost 100 outbreaks have occurred in the last 20 years after we investigated this. And the main problem is poor water supply. Pipelines are very old, old corporations, and this was a very old cantonment. They get over a period of time, they start leaking, and so this is the study which is available. I have given the reference, Medical Journal Armed Forces India, 2005. We published it. So can I have the next slide? Hetal? Yeah, this was sudden rise of viral hepatitis in military training, and over a period of 3 months, we identified 265 cases. Actually, 265, it was more than 265. We could investigate 265 cases because it was not possible to have all the cases recorded. So all cases were confined to recruits, basically military recruits. Young recruits, they come and they stay in the military training center, and the team from, as I said, we went to mobile team went to investigate. Next slide, please. So we first rapidly, this is the field investigation, how to carry a field investigation. We have to make a rapid case definition. Of course, as Dr. Hetal said, The case definition is jaundice, fever, jaundice, pain abdomen. And then for rapid screening, self-reporting, those people reporting the symptoms, we were doing the lab investigation. And rapid lab investigation in the field, we do the IgM. IgM is the indicates recent infection. Within a couple of weeks, IgM in the serum, in the blood, we can identify immunoglobulin IgM. And of course, past infection is the IgE. So if you find IgM, that means the person has recently acquired it. And then we describe it. We make a spot map. Idea is to prevent check the transmission, because the cases are increasing. We make a plot a graph and we see the cases are increasing, means we have not been able to identify the source. And these are common waterborne outbreaks. So until unless you take care of the leakage or the contamination, cases will keep on rising. So for that, we require a spot map. Next slide, please. Of course, this was the case definition. Anyone reporting with jaundice, loss of weight, abdomen, and then subsequently the routine lab investigation like serum bilirubin and liver function test, and then we send the samples for IgM. Next. So how will we confirm that it is hepatitis E? We sent samples to FMC, then we sent samples to National Institute of Communicable Disease at Delhi. We sent samples to two premier institutions. That was in the nowadays National Institute of Communicable Disease, NICD, has been renamed as CDC, India. We tested for IgM antibodies for hepatitis E, A, and hepatitis D, because we can't go on a presumption. It can be any hepatitis. So whatever the IgM, hepatitis E, A and E are waterborne. We could identify the waterborne, and we did also for hepatitis B, because the recruits, they undergo a lot of immunization and other procedures. For hepatitis B also we wanted to exclude. Next. So when we described the distribution of the cases, we went for the whole station map, and there were no cases outside the regimental center. So we were very sure that the cases are confined to the problem is in the central water supply or food supply, whatever it is. Mostly it is waterborne. Epidemiological case sheet, we made a rapid date of reporting because the movements and other things, whether the recruit acquired it locally or he might have brought it from outside the center. On history and active case finding, those who are reporting will similarly visit to the barracks to find out any cases who have not reported. Next. So what were the lab results? Out of the 190 samples sent to FMC, 185 came positive for IgM against hepatitis E. So we were very confident. 97% was positive for hepatitis E, and similarly from NICD we got report that 94% were positive for hepatitis E. So we are very confident that this is an outbreak hepatitis E. That gives us a lot of confidence. And 3-4% because hepatitis IgM rises in routine infection, then it falls down after a couple of weeks. So some cases may not manifest IgM because they must have the IgM. So above 90% we are very confident. None of the samples were positive for hepatitis A and hepatitis D. And we were very relieved because hepatitis D, as Dr. Hetal has brought down, it has got more chances of chronic hepatitis and cirrhosis in the long run. So hepatitis E, we were very comfortable. Now the second task to us, the next task to us was how to identify where is the culprit, where the water is getting contaminated. Next slide. So we had a time distribution of cases. When the cases started 24th March, it started 46 cases, and we found that some pipeline was detected, leakage and repair. So we will see in the graph that there was one small peak, there was a small problem which was taken care, cases came down, but subsequently again the cases started after stopping, and there was a huge surge. The next slide, please. So you see, we have got one small peak on the left side, And then that came down because that pipeline was repaired, and subsequently there was a huge CA, which went up to more than 265 cases, and then it came down as we could identify the problem and repair the pipeline. So this indicates a lot of, just the graph plotting gives us a lot of idea of the cause of the outbreak. And secondly, you see after the cases came down, there is no prolonged tail on the right side, because sometimes some infections like typhoid and all you get after the water contamination infects number of people. Even after the water supply is taken care of, person to person transmission continues, and that takes some time to come down. So in hepatitis C, the main source is the water supply. You see, most of the recent outbreaks are due to hepatitis E, and as it's a waterborne disease, and wherever hygiene, sanitation poor, young age, it is presumed that both hepatitis A and E infection, young people will get it. Somehow we don't get nowadays outbreaks of hepatitis A, but we still continue to get young adults. Among young adults and older adults, we are getting outbreaks of hepatitis E. Probably the immunity doesn't last long for hepatitis E, and perhaps hepatitis A, the immunity lasts. Next. So these are the cases. We did a rapid analysis. We found that this is the barracks which were being supplied by a particular pipeline. They were having more cases. They were having attack rate almost 10%, 12%. And those who are not having exposed to other barracks, they were having attack rate of 2%, around 2%. So overall, 8% of the recruits were affected in the whole regimental center. More than 1,000 recruits were there, but it was regional. The barracks are distributed. So some different barracks are having different pipelines. So one particular barrack, A, B, C, these barracks were having the major pipeline going there. They were having almost 4 times to 5 times higher attack rate. So that we could identify that the contamination may be in the pipeline going to these barracks. Next. So we identified the leaking pipes, and we found the normal pipes. So attack rate, again, we calculated number affected. 11% were affected in the leaking pipes, and normal pipes were, as I said, 5 times more. So next. So this was analysis, and then we can go for a sanitary survey. So we found what was the water supply and sewage disposal. We found the water supply network of pipelines. Water supply was intermittent. So this is important because whenever the water is not there, that's a vacuum. The surrounding contamination can be sucked in the pipelines. And it's very difficult to get the blueprint, which, as I said, most of the corporation and most of the cantonments are having very old pipelines. So unless you have the blueprint, it's 20, 30 years old blueprint. Subsequently, lot of pipelines are made, some improvisation made, something like a surgeon trying to operate, and the whole blood supply has changed. We cannot identify the arteries and the veins and the other organs. So similarly, when we do a field investigation, epidemiology investigation, until we know the anatomy of the pipeline, it becomes a little difficult. So these are the challenges we face. Next. Then very peculiar situation we found that some of the water pipes were going through the soak pits. Soak pits is from the latrines, the sewage is disposed to the septic tanks, and from the septic tanks the effluent goes to a soak pits to catch the water. And some of the pipes were going through the soak pits. And then we found that subsequently the contractor was given to lay the pipeline. He made a map and he took it to the soak pit, and the contractor of the soak pit was different. So there was a lot of communication gap between the two contractors. So the pipes were going almost to a sewage line, to a soak pit. So this was a very peculiar situation, and no coordination between the laying of pipes and soak pits. So this is again the failure of anatomical mismatch. Next. So this was the pipeline. This was a huge pipeline going through almost water logging and sewage pit right up. These were the cook houses here. These were the toilets. So the pipes, you can see the lot of mess and all. We have to dig and find out. Next slide. Next. You see, these are the soak pits. These, as I said, and we had to dig, and you find some of the pipes were going through the soak pits to the cook house. So this was such a peculiar situation, disaster waiting to happen. Next. So these were full of soak pits, and subsequent soak pits, and the water, the pipelines were going through some of them were piercing through, and some were at the side of this. Next. These are the soak pits. You see the water we dig and the pipeline was going through it. Next. I think this is when we had to lay a temporary water supply line which is above the ear, and then the cases came down. Next. So this is the year we know that most of them are due to sewage cut, and now the monsoons are there all over the country. Delhi, waterlogged, Pune also monsoons are there. So if the pipelines and other things, that this water and sanitation are the main thing. If we take care of them, all this A, E, and other, not only that, typhoid outbreaks also occur, other waterborne disease outbreaks occur, diarrhea. So many millions of children die from diarrhea every year. So these are if we take care, like safe blood can take care of the hepatitis due to blood and body fluids. Similarly, safe hygiene, sanitation, water supply, and sewage disposal, they can take care of all the waterborne. Vaccines are unpredictable. We don't know how long the immunity lasts and how many vaccines we will give, because if take care of one vaccine can control only one disease. But there are a number of waterborne diseases, there are a number of bloodborne diseases. So overall, primary prevention is the way out of this burden. Next. So person to person, then HIV is not very person to person. It's mostly waterborne and foodborne. It does not epidemic on young adults common as compared to HIV. Why debatable? As I said, HIV, hepatitis A is in young children, whereas hepatitis E in adults, older adults or older children, adolescents and young adults, because perhaps if both the epidemiology is same, both are waterborne or poor hygiene sanitation, maybe expect the children also get exposed to hepatitis C. They must be getting exposed. Probably the immunity to hepatitis C do not last long. Perhaps that's why we do not have a vaccine for hepatitis C, because if a natural infection doesn't give a long-term immunity, then perhaps the vaccine also may not give long-term immunity. So we have to get some idea from natural history of disease whether vaccine would work or not. Next. So this is the regimental medical officer. These are the recommendations we gave. You see, the water fluorination is very important, particularly the armed forces. A large number of people are staying, and one way to identify the point of leakage is you do the free chlorine test at the consumer serially. So we started doing from the source. We went periphery in all directions, seeing the water, and somewhere we find the free chlorine missing at some point. So the leak has taken just before that point, and then we ask them to dig to see for any cross contamination. So that is how we identify. And most pipeline, as I said, are old. What applies to cantonments also applies to old corporations and other. Next. So this is of course vintage distribution station health committee and all. This is from the armed forces. So actually, this gets neglected. We are actually, this pipeline, sewage, they are not very glamorous projects. So vaccines and all are promoted with a lot of glamour and film stars. So they are important to tide over a crisis, but the long-term solution is not very glamorous. It will require a lot of investment in proper pipelines, sewage, disposal and water supply. This the Western countries have already done, and we have a long way to go. Next. So these are, of course, applicable or the armed forces. Next slide. So nothing official about it. Actual epidemics like actual messy affair. Because when an outbreak occurs, nothing works. Like vaccine can only take care of piecemeal solutions. There are other outbreaks of waterborne disease waiting to happen. Like we had a vaccine for hepatitis C, that will not solve the problem because hepatitis C we do not have a vaccine. There is a lot of panic and pressure, so you have to go. In fact, when we went there, the engineer services military engineering services are very reluctant to dig. We have to pinpoint. We cannot dig up the whole thing. We have to go with a lot of logical points. We identify where is likely leak is there by serial, because water is chlorinated, and if the water gets contaminated in the distribution system, the chlorine gets used up by those bacteria or the viruses. So if the chlorine is used up, we will not get free chlorine. So when the principle of chlorination is to leave free chlorine for subsequent contamination, and if there is a subsequent contamination in the more distal part of that supply, the free chlorine will be missing. So as long as you are getting free chlorine, you are comfortable. Yes, your water leak is not there. But once you don't find at some point, so then you can dig between that point and the earlier point where you found. So textbook methods and neat plans do not work. So you have to improvise. Common sense is not so common because this is of course for the field epidemiologists. So most of the clinicians they get an idea that what is theory, and in practice it can become quite messy. Next, I think that's all. Real important things are simple: safe water, safe sewage disposal, safe hygiene practices. And these are the simple things, but they are not glamorous. So moral courage and leadership qualities are more essential than knowledge in an object situation. Shared vision rather than supervision. Because what happens, particularly in an authoritative setup like the armed forces, the first knee-jerk reaction is to hide something because they think they will be held responsible. So that is supervision. That when the team goes from A country, when the team went from A country, everybody thought it is going to be an inspection and they will be. So we have to say yes, no. We have to set a vision. What are your problems? What are their genuine problems? Pipelines are all. You cannot do anything about it. We can recommend to the authorities to change the pipeline. So that is a shared vision rather than a top-down approach. Next. I think that's all. Thank you.
I want to take a moment to express my sincere gratitude to both our esteemed speakers and the audience who attended this session. Moving on, we have received few questions from the audience. The first question is for Dr. Amitav. How effective are needle exchange programs and harm reduction strategies in controlling the spread of hepatitis among people who inject drugs?
That's a good question. There's something very peculiar about this needle spread of infections. It started, this was noted in the epidemiology when HIV started, AIDS. And now we are seeing it with hepatitis C. Because like all over the country, when we were following the HIV distribution and the mode of transmission, we found in the northeast, that is Nagaland, Manipur, Mizoram, Meghalaya, the transmission of HIV was by the route of this needle drug addicts, parental, whereas all over India the spread was sexual. So it was very peculiar about HIV. That in the northeast, it was through drug addicts and needle, and rather than the sexual mostly. And a similar thing when I think Hetal also projected the map of India. The hepatitis C is very common in the northeast. So this is again very peculiar because I have been talking to the NARI scientist also, National AIDS Research Institute, and we were discussing hepatitis C. So I was expecting it will also be sexually transmitted. Their experience also, they found mostly hepatitis C is transmitted by needle exchange, common needles, sharing of needles. And in my last almost 18 years ago, when I was posted to the northeast, I was talking to an army officer who belonged to the northeast, and I was asking why this HIV all over the country, it is sexual transmission, why it is transmitted by drug addicts. In fact, we had some interaction with drug addicts also there who had reformed. We had an education program involving the drug addicts, how to take away people from drugs, those who are. So he gave a very interesting perspective. he was born and brought up in the Northeast. He says the government wanted to check the spread of HIV, and it was through needles and other things. So they banned the use of needles. It was not available. So those who are drug addicts, they were got a craving. So they started selling the needles. And he said this can be one of the reasons why the HIV. So I think this may be the same for the hepatitis C also. Because drug addicts, they are not getting the needle. So this needle exchange program and other things can to some extent make a awareness of the authorities also. The banning a thing does not help. Like you ban liquor, illicit liquor becomes more. And if you ban sale of needles, then people will start selling it. So you have to see it from that social point of view. So this needle exchange program and harm reductions, it can be, you have to keep that in mind.
Thank you so much, sir, for answering the question with a real life experience. Moving on to the next question for Dr. Hetal. What are the recommended strategies for preventing mother-to-child transmission of hepatitis B?
To prevent the mother-to-child transmission of hepatitis B, we need to focus on mothers first. So screening of antenatal mothers to find out what is the status of hepatitis B infection in their blood. So screening of ANC mothers should be done. Second, children who are in our national immunization program, provision is there to give birth dose of hepatitis B vaccine to all the newborns. Now, this birth dose is very, very important. If the baby is exposed to hepatitis B virus from his or her mother, the birth dose will prevent the perinatal transmission. And it should be given within 24 hours of birth. If it is given beyond 24 hours of birth, it is not counted as perinatal transmission of, it is not, we are not going to prevent the perinatal transmission of hepatitis B. So this is one thing. If we come to know the mother is positive, she has got hepatitis B surface antigen in her blood, then we have to give immunoglobulins to the newborn baby also. So the active and passive immunization should be carried out the baby. Now, along with the birth dose, as per the national program, the baby should receive other 3 doses of hepatitis B at 6 weeks, 10 weeks, and 14 weeks, along with pentavalent vaccine. So that will prevent parental transmission of hepatitis B or prevent the child to become a chronic hepatitis B infection case.
Thank you, ma'am. With this, we have come to the last question for the panelists. How can public health experts engage with healthcare providers and community organizations to improve viral hepatitis awareness, testing, and treatment? Dr. Amitav, we would like to know your thoughts on the same.
I think Hetal has covered most of the things, but I would emphasize certain groups, like those who are the high-risk groups, like of getting hepatitis. So as we have learned from the epidemiology presented by Dr. Hetal, that the drug addicts, we can start involving them. And as I said, I have seen in Northeast, there are certain, like we have Alcoholics Anonymous, they have got people who have recovered from drug addicts and they become the educators. So they can give the educators to the subsequent. I have seen certain organizations like this who are working towards this in the Northeast. So that is one. And then those who are, say, promiscuous sex, like we did in HIV, high risk approach, like those who are truck drivers, long distance truck drivers, those who are migrant workers. We have to educate them on safe sex, because most of these infections which are sexually transmitted, you can include that HIV, sexually transmitted disease, or you can even hepatitis B and hepatitis C also to some extent. So this is this will integrate into the health services, which will not solve the problem piecemeal. That is only one disease at a time, because one is involving the high-risk group. So we will get the best, and they have done projects like this in among commercial sex workers also. because wherever hepatitis B is being transmitted, other HIV is also being transmitted, hepatitis C or G or whatever. And similarly, for the which are due to poor hygiene, sanitation, water supply, sewage, hepatitis A and E. So we have to involve the people mobilization to put pressure on the policymakers. Because now what is happening is everything is piecemeal nowadays. Because vaccine is very glamorous. I am not against vaccines, but vaccines can solve one disease at a time. Whereas if you follow the main cause, root cause analysis, which is the good water supply and good sewage disposal, which the attention is being diverted by the glamour of new pharmaceuticals and vaccines, which are to be used as an addition. When the water supply and the sewage system fails, vaccine is a stopgap measure. It cannot be a long-term measure because new viruses will be detected in the water supply. So we cannot continue indefinitely. So we have to educate the masses who will demand the politician and policymakers. Then only the politician policymakers will look over the unglamorous things like the water supply and hygiene sanitation. And I think Dr. Hetal can add to.
So regarding this bloodborne infection, that is hepatitis B and hepatitis C, the healthcare workers, most of them are aware, that, how they are transmitted, but their practices can be harmful. So we all know we have these practices of recapping of the needle, keeping the needle, open anywhere, not following all the universal precautions. So these are one of the, some of the risk factors which can lead to transmission of infection. So they know it, but it is not been practiced. So that should be, so that regular awareness, but only creating awareness is like, kind of just, giving them, well, it will happen. But then we need to monitor them, whether they are practicing it so that they are prevented from such, infections. Second is that this testing, we have this pre-placement examination. So we can go for pre-placement, investigation of hepatitis B and hepatitis C. Though it may not be very effective looking at the, prevention or protection of healthcare workers, but we need to prevent our patients also. So that can be one of the, policy guidelines that we should do a replacement examination for hepatitis B and C. And of course, all the precautionary measures should be followed by all the healthcare workers. Treatment, yes, treatment guidelines should be, that awareness should be created. And under the National, Viral Hepatitis Control Program, hepatitis C treatment has been, provided free of cost by the selected centers in each state or in some of the districts of each state. So I think that knowledge should be also given to all the healthcare workers. The one more thing which you have mentioned is community organization. Now, this community organization is a very, very important thing, especially for hepatitis B and hepatitis C. We have got this, we have got small setups like, we have got tattoo joints where people go for, and tattoo is now in fashion. Now, we need to make sure that the needles which are used by these tattoo artists, they are sterilized. Because there are chances, we know that the hepatitis B virus remains in the environment for long and it can be transmitted. So if these instruments are not sterilized, chances of transmission will be very, very high. Similarly, dental practitioners, they should also sterilize their equipments. All the healthcare personnel should follow sterilizing practices very, very thoroughly. That is very important. What about barber's shop? Yes, they should also follow because there are chances of cuts and there are chances of, contact with the blood. So definitely they should be also following all the, precautionary measures. Regarding hepatitis A and hepatitis E, we must follow something called as intersectoral coordination. As sir said that, public, the water distribution system is very, very important. Yes, as I said in my presentation also that where the water is purified, disinfected, we have to take care, but the distribution system is very important. From where the pipes are going, are there chances of contamination of water in the distribution system? Whether the residual chlorine is sufficient at the consumer level. All these things are very, very important. And of course, we have to give health education to the food handlers. Food has been cooked. It has been removed. There are no organism in that. But if the food handlers are not going to take precautions, they may contaminate the food. and then there are going to be outbreaks. So all these, and as I said, only awareness, we don't have to focus. We have to focus on the practice. And for that, we have to be, monitoring them regularly.
Thanks a lot to the panelists for the valuable insights. I'm confident that every attendee today learned something new and valuable. To our audience, your thoughtful questions and comments made for a truly interactive and enlightening discussion. Stay tuned to the next session in line with our program on interesting discussions from our speakers. Thank you and have a great evening ahead. Happy Dogplexing.